Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Sherry and Rosalie Exline Ziegler Fund. Thanks for joining us, and you're in for a treat today, and so am I, because my friend, Dr. Sue Beck, breast cancer expert, is with us today. Dr. Beck is the medical director of the MercyOne Katzmann Breast Center at the Mercy Health Center, Comfort Health Center for Women. And welcome.
Thank you, Dr. Deming. Thank you for asking me.
Yeah, we've been working together for 30 years at least.
Yeah.
So Dr. Beck grew up in Des Moines, Roosevelt
Yes.
High, went to Iowa State, and then got her medical degree at Des Moines University, her residency in general surgery at Mercy, and then did a fellowship in breast surgery, and directs our breast center at Mercy.
Yes.
And when did you come on staff as a general surgeon?
1989.
You know what? We started the same
time.
year.
We did.
We both started 34 years ago. How come I look so old and you look so young? Wow. I think I might have to start wearing pink if that would make me look as...
Thank you.
But seriously, so maybe to start, like, when you went to medical school and when I went to medical school, we probably had, let me just speak for myself. I went to Creighton Medical School, probably had maybe 10 to 15% women. Now it's well over 50% of medical students are women. What was your experience, and what made you decide to become a doctor?
Well, you're right. There weren't very many women in my medical school class, 30. And that was at Des Moines University. And I'll never forget, one of my lecturers was a urologist. And he came in, he looked up at all the students and said, I have never seen so many women in class. They probably won't ever rotate with me because I'm a urologist. So like you're asking me to jump out of a plane, of course, I took that.
Yes.
And that was my first rotation.
With that particular...
Yes.
urologist.
My first year, just as between my first and second year as a student.
Oh, and the poor guy, he's probably trying to shield your eyes from seeing what you're supposed to be seeing.
Well, urology's changed a lot, thank goodness, for men since then. But I did spend a lot of time in the operating room, and I think that's probably where, I really became interested in just the surgical aspects of medicine. I grew up, my dad was a dentist. And so he was always into all kinds of science, and even astronomy. We'd go to Waveland to the observatory. We do all those things, and so I loved science always as a kid. And when I was still in grade school, they had a Saturday science class at DMU, and I went to that. And so I had two uncles who were osteopathic physicians. They both practice in Colorado.
Oh, okay.
And so
your dad's brothers or your mom's?
My dad's brothers.
Your dad's brothers were
both of them
physicians. Okay.
Yeah. So there's been a lot of changes, a lot more women now, and which is really nice. I will tell you that it was really hard, I think, for some of the women first starting, especially those that were married, didn't always make that through. But what was interesting when I graduated, and especially from surgical residency, of course, my name is Susan Beck, and the only other really general surgeon, colorectal surgeon in town was Susan Beckwith.
So, yes.
So it was kind of a...
Susan Beck and Susan Beckwith, the two female doctors.
Yes. So...
and then you chose surgery. So yes. I would say back in the day when we were in medical school, it was more common for the women physicians to go into pediatrics or OBGYN. And surgery was then very male-dominated. So how many female residents in your surgery class?
Well, in our class, it was one per year, and I was the first female in that general surgery program. And it took several years before we recruited another female. And of course, now we have 4 per year. So we have about, in our program now at Mercy, probably 50% are women.
And that's the general surgery
General
residency
surgery,
program.
yes.
So not only are you a breast surgeon and run the breast clinic, but you're also one of the instructors for the general surgery residency program,
Yes.
training new ones. And that's got to be very professionally fulfilling. And one of your students is going to come back now, is just finished your general surgery residency, and now is finishing up a breast fellowship and will be joining you
Yes.
as one of the board certified breast surgeons at the MercyOne Katzmann Breast Center.
Yes, in fact, one of your previous guests, Dr. Tiffany Torstenson, who's been my partner for 10 years here now, she was one of my residents and graduated fellowship through Mayo. And my new partner is Devin Foster, and she'll be coming back from Emory for a year there. So it brings a nice mixture of
Yeah. And I have to, and I don't mean this to be sexist in any way, shape, or form, but I really like that we've got 3 female breast surgeons. I think I can only imagine how comforting and just how comfortable it is for patients to come to see you and Dr. Torstenson and Dr. Foster for breast issues.
I think I see that exactly in this part of general surgery. But when I first started in general surgery, some of the men weren't so excited to see me for their hernias. They prefer to see a male.
Yeah.
But
And they probably are in a state of shock when the female urologist walks in to do their vasectomy.
Yes.
Yeah, we'll get over that. We're making progress. I'm sure when you started, if you had $1 for every time someone called you a nurse, you would be really wealthy. Because you walk into the room and they assume that you're the nurse and the little male medical student is the doctor. but that's changing now with over 50% of medical school classes being women, and because of trailblazers like you. So obviously it's nice to remember that you and I came to Mercy at the same time, 1989, 34 years we've been in practice, shared many, many patients. Yes. And we're going to have a conversation tonight about breast cancer, and that's changed a lot in the last 34 years. Just in broad strokes, before we get into things specific, what would you say has been the biggest change in the way that we manage breast cancer now compared to the way you and I managed breast cancer in 1989, or even take it back earlier, let's say when we were in medical school? I graduated medical school in 1980.
Yeah. And so I'd say the biggest change, and seeing what breast surgery was like in the 80s when I was resident, is the woman would come in with a breast lump and they would have to sign a paper that they may wake up without their breast.
So before you even did a biopsy, you signed a consent form saying, we're going to see if this is cancer, and you have to consent that you might not even have a breast when you wake up from this procedure.
That's correct, because this was before the core needle biopsies, all the advanced imagings that we used to do. Towards the end of my residency, we would do a core biopsy while the patient was asleep under anesthesia of the palpable mass, and then do a frozen section, and then
the frozen section is where, while the patient is under anesthesia, the pathologist looks at the tissue you've just removed, a little piece of the tumor, and they tell you, while the patient's still under anesthesia, is this cancer or is this not cancer?
Yes, that's correct. And that was kind of a new thing back then. Because otherwise, before, it was you would just do an open biopsy, then send it to the pathologist, and then if it was positive, you do the modified radical mastectomy, which means taking the breast and the lymph nodes under the arm.
Mm-hmm. And some of the chest muscle too, right?
Those are radical. We didn't have to do that then because we were already at modified radical at that
Okay.
time.
So back before our time,
Yes.
the breast cancer surgery over the last 100 years has really progressed from being, okay, we didn't have chemotherapy. We did have radiation, but it was like, we just got to remove more tissue. And if we remove more tissue, we have a better chance of cure. That was the Halstedian approach.
Yes.
And let's not just remove the breast, let's remove the breast and the chest wall muscle and all of the lymph nodes, and let's just remove as much tissue as possible.
Yes.
And what we've learned over time is that if breast cancer is going to spread, removing a lot more tissue didn't actually improve the cure, just caused a lot more side effects. So over time, we've gone from radical mastectomy to modified radical mastectomy to lumpectomy and axillary dissection to lumpectomy and sentinel node. How long does it take to adopt and adapt to the newer science that leads us to doing smaller surgeries and removing less tissue?
That's an excellent question. It took longer before when Fisher was doing all his studies for lumpectomy, Veronese in Italy, doing the lumpectomy trials and finding that we didn't have to do mastectomies for all these. It took a while for U.S. to really adopt that.
Yeah. And Bernie Fisher, run the NSABP, and that was the organization that did the clinical trials in the United States that compared lumpectomy to mastectomy.
Yes.
And showed
equal.
Yeah. That if you did lumpectomy plus radiation to the rest of the breast, it was equal in outcome to doing a mastectomy.
That is correct. And that was huge because people could still keep their breast and have a good quality of life because, with a mastectomy and removing lymph nodes under the arm, that has side effects. Those side effects being sometimes just movement and feeling of the muscle, but also potential swelling of the arm or even the chest wall or even the breast. So.
Talk a bit about multidisciplinary care, and then maybe describe for our audience what a multidisciplinary breast cancer conference is all about, and how the number of different types of doctors are involved in the decision making about how to treat someone with breast cancer.
So we found out over the years that breast cancer isn't just a local disease, that it is systemic in nature, and thus we have to approach it in a multifaceted way. And we've learned that, and we've learned that it takes a team of 3. The surgeon, still surgery is a first-line defense and treatment for breast cancer, but it can't be that on its own. And especially now, the question that you had before, how things have changed, where we've learned about the biology of the tumor, makes it so that we can have our multidisciplinary team of our medical oncologists and our radiation oncologists really help target treatments to really make it individualized.
Yeah. And I would say, just to amplify that, those are the sort of the 3 treatment specialties, but then the pathologist doctor plays a huge role. Most of the time, the patient never meets the pathologist. No. And the diagnostic radiologist, the radiologist who reads the mammograms, reads the MRIs, reads the ultrasounds, plays a huge role. And so there's many individuals that are part of that multidisciplinary team.
Right, and many more. But to just piggyback on the pathologists and the radiation radiologists, we are so blessed in Des Moines and at Mercy to have some of the best pathologists to read breast. I think they read more than anywhere in central Iowa. And our radiologists are well versed in all the new techniques as far as image guided biopsies. But not only that, we have very nice equipment that can see these very, very small lesions.
Hmm.
And with some new targeted CT
New PET scans for
scans.
breast cancer
Yes.
specific. That's just came
Exactly.
out this year. Yeah. And so once a week, we have our multidisciplinary breast cancer conference that Dr. Beck chairs. And Dr. Beck and Dr. Torstensen, the two breast surgeons, soon to have a third one joining later this summer. And the radiation oncologists are present, the medical oncologists are present, diagnostic radiology is there, pathology is there, and they've taken pictures of all of the slides, and we show all of the x-rays. And then we also have some advanced personalized genomic testing of cancer cells. So, it used to be the pathology was just the pathologist, the human being, looking at the slides under the microscope and saying what this cancer is. And now we do special stains, decide if there's estrogen receptors, progesterone receptors, overexpression of HER2 protein. We can send off pieces of the tissue, do genetic and genomic and molecular testing on the cancer cells.
Yes.
Maybe explain a little bit about genetic testing on an individual to see if they have the BRCA gene or another mutation. So the genetic testing on the patient and genomic testing on the cancer cell, and how both of those factor into how we treat a patient.
Right. And we do have a genetic counselor who attends our multidisciplinary conference as well as our clinical trials. Professionals that are there to help us with this very exact differentiation of certain types of tumors. So there is a difference between overall body genetics and genomic testing. So just to clarify, the whole body genetic testing, you've heard of BRCA1 and BRCA2, BRCA genes that increase a woman's risk of breast cancer over their lifetime, of BRCA1 up to 85%, BRCA2 about 60%, but also the various co-cancers that can occur with that, including ovarian and even pancreatic and male breast cancer. So when we see our patients and we talk to them, or even if they're seen in mammography and they have a risk score and family history kind of delved into, we find that certain patients are a candidate for genetic testing, and that is a swab, a buccal swab, or a blood test. And
so either just swab some cells off the inside of the mouth,
yes,
the cheek, the inside of the cheek, or submit a blood test. Either of those will get the human cells that then the lab can do all of the genetic testing on the individual.
Yes, and you cannot be discriminated against for that test. So just so you know that is safety in that. And, if you do have a mutation, you can be past 50% of the time down to a child, male, female, it doesn't matter.
So if I tested and I have BRCA1, 50% chance that each of my children would inherit that BRCA1 gene.
Potentially, yes. It's a 50% transference. Yeah. Sometimes they'll skip, and sometimes if the father had it and the mother had, they can have both mutations. So both sides of the mutation of BRCA1 and BRCA2. We just had a patient who had both, which is kind of the first I've seen of that. But so you have to have two complements there. So that's very important and helps us with screening.
What are the implications if a woman's been diagnosed with breast cancer, you do her genetic testing and you find that she is BRCA1? How does that change the treatment you're going to provide that woman?
So first of all, if that woman has children, we do offer testing of the children then, and that's paid for. And that helps us with screening.
Sisters or siblings.
Yes. But for that patient, it can impact surgical decisions while working up their best treatment for their cancer. And still, with a mutation, if they're 68, 70 and have a mutation and are dealing with that, they wouldn't necessarily have to undergo a radical mastectomy, or I shouldn't say radical, a bilateral mastectomy for prevention. They could still have breast conservation, and then we put them on a really tight screening program. But if they're under the age of 50, plus minus 10 years on that side. We do offer a more, treatment plus a preventative treatment all in one, which would be a bilateral mastectomy. And there's so many different kinds of mastectomies now.
So the mastectomy on the side with the cancer not only removes the cancer, but then you're removing the rest of the breast tissue that over the next decade or two, because she's BRCA positive, could develop a future cancer. And then you're also removing the other breast. Yes. Not because there's cancer in there, but because if you have a BRCA1 mutation, there's an 80% chance you could develop breast cancer in the future. So that's a situation where you may remove both breasts completely, as opposed to just doing a lumpectomy.
That's correct, and that can be done at the first surgery, and we can do immediate reconstruction now with Dr. Sam Reese. He's very talented in helping us with the reconstruction on those patients.
He's a plastic surgeon.
He's a plastic surgeon.
Mm-hmm.
Yeah.
So, I mean, we're talking about this. So the first time I saw this, it really just blew me away when I saw a woman who came in and had bilateral mastectomies. And when you examine her, it looked like she still had her own breasts. So we call this a nipple sparing mastectomy. Explain what that is and what the end result looks like.
Yes, I can. And in relation to genetic mutation as well, that's important, because back in the day when we attempted nipple sparing, they would save a pretty large button of tissue underneath the nipple, worried that they wouldn't get enough blood supply. But we found that there was increased risk of cancer there. Now the nipple sparing mastectomy is where we make an incision, just what we call the inframammary folder, right underneath the breast. We're able to make the incision in there and go all the way up to the clavicle and separate the breast tissue from all that tissue, and really
so from under the breast up to the collarbone.
Yes.
Underneath the skin.
And underneath the skin and off the muscle. And with that, it's just a skin envelope with a nipple, but we don't leave any tissue underneath the nipple. And we found that even with making it very thin, almost like a skin graft, it still survives. And so we do get that very nice aesthetic result that you were talking about.
And so you remove all of the breast tissue and then leave the skin and the nipple. And then in the place of the breast tissue, you have a couple of options. You can either put a silicone implant and just close it all up, or you can do a tissue expander. Yeah. Explain what that is and why you would do that.
Right. So a tissue expander is just as it sounds. It is a silicone shell that we can fill after it's been implanted with saline or air, even to fill that space over time. And it is used in those patients that may have very, very thin skin, or we're concerned about the tissue staying alive because we have taken all the blood supply from underneath the skin because we've taken the breast out. And this just offloads that surgical site so the blood vessels still can function appropriately and feed the skin.
So when you first put them in, these tissue expanders are small, and then you gradually, through a little port, inflate them over the course of a couple of months, maybe.
Yes. Usually every 2 weeks or so, and it does give some patients, especially women who do this procedure for prophylactic reasons for the genetic condition we talked about, they can determine what size they want to be. So it can be helpful that way. But we have techniques now that make it even safer. It's just not the skin over the top of the implant. The plastic surgeon wraps it in a very nice collagen matrix. So it gives it another barrier. So it really
Mhm.
reduces infection. So before there was a lot of infection. So we'd put everything underneath the muscle and stretch the muscle. We don't do that anymore. That was extremely painful. And the implants rode too high. But now we can put the implant reconstruct appropriately on the chest wall.
So you put do the expansion, and then after it's been stretched out and expanded far enough, then there's another surgery where you go in, remove the expanders, and put in the permanent,
Yes.
softer silicone implants.
Yes. And that's a very short procedure, and it's outpatient. The first procedure is about 4.5, 5 hours, and it's all in one, the cancer surgery and the mastectomy and the reconstruction all at that same day.
And often removing a few lymph nodes on the involved side.
Correct.
Mhm.
Yeah.
So what year do you think that bilateral nipple sparing mastectomy was first done at Mercy?
Well, the American Society of Breast Surgeons, which really started in 1997, was really the group, a national, actually global surgical group that really started investigating some of these newer procedures. And they kind of had not a clinical trial for it, but they had a registry for the nipple sparing. And I'll have to tell you, the nipple sparing's changed as well from that time to now. I would have to say maybe 2000, maybe 2004, 2000, in the early 2000s we
So
started.
about 20 years ago.
Yeah, and the nipple incisions changed. They used to be around the nipple, and then it used to be kind of a sideways incision off the nipple. And now we know it can be underneath because we have better equipment, better light. And ergonomically, it's not the easiest procedure for the surgeon, however, but it does make a very, very nice reconstruction. And in fact, like you said, some people still want their patients to get mammograms, and we say no, they cannot have mammograms.
You do not have breast tissue. It looks like you have breast, but you do not have
You do
breast.
not have.
Let's go back to, again, our multidisciplinary cancer conference. And we talked about various forms of surgery, but we talked about how for those patients for whom breast cancer isn't cured, it's not usually because we don't get the breast tumor out, but that cells have spread either to the lymph nodes through the lymphatics, or has gotten into the bloodstream and gone to some other part of the body.
Right.
And no matter how big a surgery you do, you're not going to take care of that. So this whole role of systemic treatment, which we used to say chemotherapy or hormone therapy, but now there's all sorts of different forms of medicine to treat cancer cells. There's the sort of the old-fashioned chemotherapy. There's the anti-estrogen treatment, but there's targeted therapy against HER2 overexpression. There's immunotherapy that boosts the immune system. And as chemotherapy developed, it was always like, well, do the surgery first, figure out how much cancer there is, and then decide whether to give the radiation and the chemotherapy after the surgery. Now there's this whole new concept that we call neoadjuvant, where you move the chemotherapy up front before the surgery. Under what circumstances would a woman get the chemotherapy prior to having the breast surgery?
Yeah, that's an excellent question. And just to pop back to genomics, a lot of times we can check the cancer cell for not only risk of recurrence, but if it were to respond to chemotherapy, or would it do a better job with endocrine therapy first? And what we mean by neoadjuvant is before surgery, and adjuvant is after surgery. So that's additional treatments. So let's say a young woman, 40, comes in and she felt a lump, image-guided biopsy was performed, and she has what's called a triple negative breast cancer. One, that the cell doesn't respond to estrogen or progesterone or HER2, which is a communicatory protein in our body. And let's say she has an enlarged lymph node that was sampled, and it was had some metastatic cancer cells there. Going in and doing surgery first wouldn't necessarily be her best option, because that tumor is extremely sensitive to chemotherapy. So that would be a woman that we would send to the medical oncologist first to be
And it also is a
evaluated.
tumor that has a high predilection to spreading
Spread
to other parts of the
to
body.
lung, liver, bone, or brain. And so we feel that, the science has shown that treating these women with chemotherapy first, we can actually get a complete kill of all the cancer cells. And you may ask, well, then why do we have to do surgery? And it's to prove that we've had a complete response, is what we call it, where there is no live cancer cells left, either in the lymph node after we remove it or at the breast. And that is a wonderful, excellent prognostic indicator that the woman would have a much better overall prognosis.
Another situation where treatment up front is often done is for patients with a HER2 positive breast cancer. Maybe
Yes.
talk a little bit, explain what does it mean to have a HER2 positive breast cancer, and what are the treatments that are done just for patients with HER2 positive breast cancer?
Yes, when a woman has her cancer biopsied, and we check all those receptors, those little keyholes on the cell wall that stimulate the breast cancer cell to grow. An abnormal cell will have maybe thousands, like a golf ball, all over it. And so the Herceptin comes along in the bloodstream and attaches, and that cell's just greedy for more, and it just gets overstimulated to where it just starts growing out of check. And Herceptin was found to be very effective at blocking those little keyholes on the cell, those little receptors. So then that cell would just not proliferate, and it would die. This Herceptin has been so effective that it's totally downstaged our whole staging system for breast in those patients that were HER2 positive. Before Herceptin, it was a very poor prognostic indicator because it would oftentimes metastasize to the brain. It'd have metastatic sites. So that's been an incredible improvement. And those patients do have a whole year of that Herceptin medication that they receive. They get the standard chemotherapy up front as usual, and then the Herceptin follows. And we've had excellent success with that. So it's been a credible achievement. And then on the counterpart, those patients that have, say, an estrogen positive tumor, very low proliferation index, that show on genomic testing that it doesn't respond to chemotherapy very well, that's when we give that hormone blocking agent, which similarly blocks those little keyholes on the cancer cell. And sometimes we can get a complete response on certain tumors just by starving it of estrogen from the woman's body, from the either ovaries or adrenal glands.
There's been in the news this week some reports about changing the recommendations for mammograms. So let's switch gears a little bit. Let's talk about risk factors for breast cancer, prevention of breast cancer, and then screening for breast cancer. So let's talk about screening. So most people might know, but screening for cancer means somebody who doesn't have symptoms for cancer, but undergoes a test to see if you have it. And breast cancer is one of the classic, where screening mammography has been shown to save lives. So women who don't have breast cancer go in and get a special x-ray of the breast called a mammogram to detect a cancer that might be too small to feel, and that finding breast cancer at an early stage actually leads to a higher cure rate. And over the years, like how frequently should we get mammograms has been studied.
Yes.
And because we are practicing evidence-based medicine, as years of study yield certain results and then years more of study yield different results, sometimes those recommendations change. And just this week, there's been a change in the recommendations for who should get mammograms, at what age should it start, and how often should you get them. Do you want to take a stab at
Sure.
describing where we are right now?
So when we were in medical school, it was zero mammography, which was a totally different blue-backed type higher
were
radiation.
No screening mammograms.
No, it was just the beginning. But now, of course, with 3D mammography, less radiation for patients. I think some people still were concerned about the radiation from mammography, but it's really less than radiation than getting in an airplane and flying from here to Denver, Colorado. So we're able to tell women that. But yes, the U.S. Preventative Service Task Force, initially, was it about 10 years ago, roughly 8 to 10 years ago, came out with recommendations. Hey, are we causing more problems than helping with screening? And we think for the average risk women, we should have mammograms only done every other year, starting at age 50 and stopping at age 79. And this was discussed over and over, and many of the physician groups weren't necessarily in agreement. OB-GYN was not in agreement of that. The Society of Medical Breast Imaging, not in agreement with that.
Even the American Cancer Society said, because it had gone from 40 to 50.
And every other year.
It was, instead of start at age 40 every year, it was no, start at 50 and go every other year.
Yeah.
And
for average risk. But over the years, and you've been so instrumental in helping with the dense breast legislation and everything, we found that maybe we're missing a subset of population, and so it took the U.S. task force to come back and look at things again. And so they just came out. It's still not 100% like I guess most of us would like, which is starting at age 40 and every other year. But they do address several things, and that they did come to biennial or twice every other year, starting at age 40 for average risk. But then they did talk about also determining what a woman's risk is, and that's either when they're between 25 and 30 years of age, finding their family history and finding what their risk. That doesn't mean starting any mammography then, just knowing what their risk is and instructing on self-awareness. And in that group, oftentimes we start, if there's a problem, with ultrasound or something like that.
So let's back up just a little bit. We're talking about risk, and we're talking about these recommendations of average risk. What are the situations that puts a woman at higher than average risk of having breast cancer?
So certainly we need to know family history.
So if you have a family history, especially a first-degree relative, which would be either your parent, your sibling, or your child would be a first degree. Right. So if you have a first-degree relative with breast cancer, that certainly automatically puts you at higher risk.
Yes, and add ovarian in there, and then multiples of maybe secondary family members.
So 2 or 3 second-degree relatives.
Yes, yes. So that's important information as well.
Having a genetic mutation, your own mutation that you know about, would put you at higher risk.
Not having a very early onset of having an early onset of menstrual, we look at that.
Okay.
Late menopause, not having kids. Nulliparity, that also looks, those are kind of non-modifiable risks. Modifiable risks would, also be alcohol intake and tobacco. And then now certainly the dense breast issue.
And obesity factors in, especially for postmenopausal breast cancer, increases the risk of women after menopause getting breast cancer.
Yeah.
And then the last one you said, and sorry, I sort of stepped on it, was breast density. Talk about the relationship between, first of all, what does it mean to have a dense breast? How's that defined? And second, how does having a dense breast put you at higher risk for breast cancer?
So that's an excellent question because the radiologists have done a really good job as far as rating the breast density. So on mammography is how it's rated. And, women can have anywhere from very fatty breasts, where on mammography that looks just very dark. You can see through the breast very easily.
And on a mammogram,
On a
fat
mammogram,
looks black. And breast tissue looks white. So if you have a
yes.
mammogram and it looks like all black, that would be a very low dense breast. Almost all of the tissue is fatty equivalent.
That's right. And just the opposite then for a D category, which is dense and it's on whiteout.
Mhm.
And so it makes it very difficult for the radiologist to look at patterns because that's what mammography is. It looks at calcifications and patterns. And if it's whited out, they cannot see the architecture.
And often a spot of breast cancer will show white. So if the whole breast is white and you're trying to find a little white spot in an entire white breast, it's not going to show up very well.
That's right.
Whereas if you don't have much density and it's a black breast, a little white spot really stands out.
And we used to think that, well, all young women will have just dense breasts. It'll all be the same. And as we get older, they get less dense. Well, in some women, that does happen. But you can have an 80-year-old woman with extremely dense breasts as well. So it doesn't have to do with age necessarily.
And so the thought is that dense breasts, you probably actually have more breast cells than if you have a fatty, so that just by sheer numbers, you're more likely to get breast cancer. But then also there's the detection rate.
Yes.
That not only does having dense breasts increase the risk of having breast cancer, it increases the risk that you're not going to find it.
Yes, correct.
At a small size. And so one of the, and we both worked on this legislation, breast dense legislation. Now in the state of Iowa, it's required for women who get mammograms for the mammogram report to tell the woman, does she have dense breasts or not? And as you've explained, the mammography doctor calls it an A, B, C, or D. And that's just a scale from A to D. A and B are breasts that are a little less dense than average, C a little more dense than average, and D very dense breasts.
That's correct. It's kind of subjective a little bit by the radiologist, but it's a pretty accurate scale. And it really does help us as clinicians and for patients who are in our high-risk clinic, and our high-risk clinic includes those that have a greater than 20% lifetime risk for breast cancer. And so it helps us monitor those patients either every 6 months or
And let's
MRI.
take the example of a woman who doesn't have a history of breast cancer, but has dense breasts and other high risk. In addition to do the mammogram, and you just sort of said that, what else would you do for a woman at high risk of developing breast cancer?
Right. So MRI certainly is the gold standard. There are some other things out there called ABUS, or the automated breast ultrasound, where it is a very large transducer that goes over the entire breast. Just a few places do have that, but there's a 20% false positive with that. So the MRI is very accurate. There's some drawbacks to MRI. Certainly, you're not squished between two plates in a mammogram, but it is a longer test. It's about 20 to 30 minutes. It requires an IV, and dye is put in, laying on your stomach. And the whole premise of it is the dye runs into the breast, and it shows the blood supply going into the breast. So at any time, the blood supply stays really intense in one area of the breast. That's not normal. You should not have new blood cells starting to develop within the breast. It means something's growing, and there really shouldn't be something growing there. So that's how the MRI is so specific on that and helps in dense breast tissue.
But there's not enough MRI scanners in the country to use it as a screening test for every woman. give?
No, there isn't. But we have new technology called nuclear mammography, which might be coming out soon, which is a mammogram, but the dye is injected. You wait about 30 minutes and then that imaging is done. And so that's kind of I guess, a knockdown MRI in a way.
Before we're going to open it up to questions pretty soon, because I know we're going to have lots of questions. Being a breast cancer doctor is not just about removing cancer cells from a woman's breast. Maybe talk about your philosophy of care. I can only imagine what it's like for you, how many times a week to have to call up a woman and say, you have breast cancer.
Yes.
And how have you developed a way of doing that with compassion and attention to the human element of, one human being caring for another human being?
So I'd have to say the majority of time, when a woman comes in to see me, they have their diagnosis. So I don't always have to do that first call where our radiology navigator does a lot of that, and from the radiology department. So that's kind of the bomb. And then by the time they come to see me, then we're picking up the pieces, and it's super scary for them, and rightly so. Part of going through this and talking about the disease and the process and building their care team, it takes time. And I get in trouble with that sometimes because my appointments run late because I
Because you take time with your patients.
Talk too much, but that's the mental part of it. I mean, I so believe in that as a physician, that you have to be sensitive to that part and you have to listen as much as you can, because we always think that, okay, we need to pull you down from the ceiling here for just a little bit and to get perspective as to what this tumor really is. We're going to go after this for curative intent. This is what we have available. And then we do our exam to just try to show. I have an ultrasound in my room, and it just helps to have the visual. And of course, it always helps to have family members in there as well, and they are just as scared sometimes. But my philosophy on that is to give as much information, and all the positives mixed with the negatives that might be on the diagnosis, but a plan, that we have a starting plan, that we're going to get a team. And yes, there's going to be a lot of appointments to start with. But then when we get through all those steps, we are hoping and striving towards a curative intent.
And having a plan can be so calming.
Yes.
Mm-hmm.
Yes. And, we're not always successful. And it hurts us just as much as the patient. So oftentimes I enjoy talking to my patients because they're curative for me too.
Mm-hmm. Yeah, it's wonderful to see follow-ups that you just can hug and give good news. So
yes.
Hug works in both directions.
Yes, it does.
Yeah. So we're going to open it up for some questions. So questions for Dr. Beck.
So first of all, I did not have my surgery at Mercy, bilateral mastectomy. So, and my tissues. So who decide on those tissues if they're stored or if they're not stored, and how long?
So
Say that again. Who decides
if the tissues, the cancer tissues, if they're being stored at a site?
Oh, so if we get it all or not? Your question is, how do we know that we get all the cancer cells, or if they could be somewhere else?
If they're stored someplace, the pathologists, do they store
Oh, at the
those?
pathology department?
Yeah.
Yes, they have it at least 10 years.
Okay.
Yeah.
All
At
right.
least.
Yes. So the biopsy specimen is retained in the laboratory, and the surgery specimen, the cancer cells, are retained in the laboratory.
Yeah.
So those tissues are available for at least 10
I thought
years.
at least.
Many large centers will keep that tissue for longer
Longer,
than is
yeah.
minimally required.
Okay.
So that, yes, there are situations where we may go back and look at a piece of a tumor that it was removed from the body a decade before and do a test on it that wasn't a test that we didn't do back then that we now know we can do.
Right.
So every woman's tissue, breast tissue, is stored.
Okay. And
Large,
that's-
some of the larger specimens, I think maybe not so long, but the slides will be there, and we can do genomic testing on slide tissue.
Okay.
Which is
well,
amazing.
Mine has been lost.
Yours have been lost, as you said.
Yes, or thrown away or something. So
Yeah.
yes, but it wasn't at Mercy. Anyway, second question: women with bilateral mastectomy, do you see breast cancer coming back?
So the question is, after mastectomy, do you see breast cancer coming back? So 1 to 4% of breast tissue remains after mastectomy, whatever mastectomy you perform. Why? Because there's no good capsule around the breast tissue. The breast tissue kind of undulates underneath the skin along the ligaments of the breast, called Kupffer ligaments, and those little cells can still be there. And even though it's rare that it can come back at the mastectomy, post-mastectomy, it sometimes can, especially those with mutations. Sometimes that's why we still follow mastectomy patients with clinical exams 6 months if they have a genetic mutation, every 6 months. And then we add ultrasound or even MRI for surveillance if we need to, or if there's a new symptom. And then the biggest thing after mastectomy is teaching our patients to look at themselves and to know their norm, know what the skin looks like, what they feel, and to consciously do that at least once a month. And we probably do it more, but just to know, because if you do that, then you know there's a change. And sometimes those little tiny recurrences, if they do occur on the skin flap, can be managed very locally. But it does require then, if that happens, we do some more advanced testing to make sure it's nowhere else in the body.
Thank you.
Yeah, I have a question, but I wanted to add, when I met Dr. Torstenson was my surgeon. She's
Yes.
awesome.
Yes.
When I met with the nurse navigator, and sat down, didn't think to say, hey, I could have my husband come out from the lobby. She showed me everything, and she goes, you're awfully calm. Are you okay? So when you mentioned about being up there and you're being pulled down, and I said, no, I've had cancer on both sides of the family, so cancer is not unfamiliar to me. And I said, then it finally hit me. I go, what do I say to my husband? And tell that you have a little bit of cancer. And then I said, it's like telling him I'm a little bit pregnant. And we both laughed, because it's like, it didn't make sense to say that. And then another incident, when I had to go for the MRI, to handle it, I have to sing because it's so loud. And I forgot to warn the tech, and she stopped everything. She goes, are you in pain? Are you okay? And I go, no, I'm singing, but thank you. So those are a fun experience, but it's kind of tagging on to her question. I had a lumpectomy. So, and in that instance, like, I've had scare where I've examined, I went, oh no, I feel something. It feels like a lump. And then I have it verified. It's not, it's like scar tissues and all.
Good job.
Is there still that concern as a lumpectomy? I could get it on the other as well, breast, or?
So the data shows that lumpectomy compared to lumpectomy is radiation therapy with help of Dr. Deming, and whatever systemic treatment is required, it's sometimes less. And it's because radiation therapy plays such a big part. And sometimes with mastectomy, radiation isn't employed. It may not reach those thresholds. So I'll have Dick comment on that more, but it's maybe that radiation was actually the better part of the treatment, or the combination of all. So don't feel that you were slighted in any way having a lumpectomy. And I know that Dr. Torstenson's following and surveillance you on the other side. And it doesn't necessarily jump from one breast to the other. If it's going to do something, it's somewhere inside.
Thank you.
Yes. So getting back to the initial trials that were done in the United States that demonstrated that lumpectomy was equally effective, there actually were 3 groups of patients. So the trial randomized patients to either having a mastectomy without radiation, a lumpectomy without radiation, or a lumpectomy with radiation. And the study showed that at 10 years, the patients who had lumpectomy without radiation had a significantly higher recurrence rate in the breast. The patients who had a mastectomy or lumpectomy with radiation had the same very low recurrence rate. And over years and years following, there's been a slightly higher local recurrence, meaning in the breast, for the mastectomy than the lumpectomy plus the radiation having an effect on the rest of the breast tissue. But those women who had the lumpectomy without the radiation still had the same survival. So even though they had a much higher risk of recurrence in the breast, when it came back, it still could be cured, usually by doing a mastectomy. So all 3 groups, after being followed for 20-some years, had the same cure rate, but the women who had the lumpectomy without the radiation were much more likely to have to undergo further treatment in the breast because it recurred. So one of the things we're looking at now is the radiation does have side effects, though, too. And when you have some types of breast cancer, so a woman who develops a small breast tumor after menopause, where the breast cancer is estrogen receptor positive and progesterone receptor positive and HER2 negative, the cure rate is like greater than 95%. So the question is, do those women really need the radiation? And some of the studies we're doing now are backing off and actually intentionally doing less treatment, because we think that less treatment will give the same excellent cure rate but fewer side effects. So you're seeing initially with all of cancer treatment, it was like, what can we do more to get a better cure rate? What can we do more to get a better cure rate? Once you get cure rates that are over 95%, it's appropriate to ask the question, what can we do less to have fewer side effects? And that's one of the fields of research now. We have time for one more question from the audience.
What percentage of your patients are men?
About we see about 6 a year. It's about 1%. A male breast cancer is there, though, and we do have our patients that come in, and they're some of the best patients that we have. Some of the treatments that we use for women with estrogen positive breast cancers and a male who comes in with estrogen positive breast cancers, sometimes the medications, the oral medications we use for that are challenging for the male breast cancer patient. And then we always check for genetic testing if you're a BRCA2 carrier, if you have a breast cancer, if a male has a breast cancer. We do see a few, and most of the time, those patients require a mastectomy. I will say, however, I do have one male patient now who's getting neoadjuvant chemotherapy because it was such a large area underneath the nipple. So he's getting chemotherapy first, and then we'll be doing his surgery. Now for him, we'll have to do a mastectomy because it's totally involved his nipple. But there is discussions on nipple-sparing mastectomies for men. For some situations, they'd have to be at least 2 to 3 centimeters away from the nipple for that to even be considered, because there just isn't that much male breast tissue that's there. So,
Great.
but they're treated the same.
Thank you, everyone, for your questions. Thank you,
Thank
Dr.
you.
Beck. Thanks, Sue, for being such a great physician for all of our patients, for being such a great colleague and a friend, and for being so caring and compassionate with all of our patients.
Well, thank you, Dick. I appreciate it. And I appreciate all the help you've given me over the years. And we're really not that old, right?
Yeah, right. Yeah, we probably have another 50 years of practice in us. So I want to thank everyone for attending. If you know someone that would benefit by watching or listening to this program, it will be available on demand at the Above and Beyond Cancer YouTube channel or the MercyOne Cancer Center website. And please join us again next week. Thanks, everyone.